At Baptist Health South Florida, it's our mission to care for you when you're injured or sick and help you stay healthy and fit. Welcome to the Baptist Health Talk podcast, where our respected experts bring you timely, practical health and wellness information to improve your family's quality of life.
Welcome, Baptist Health Talk podcast listeners. I'm your host, Dr. Jonathan Fialco. I am a preventive cardiologist and lipidologist at Baptist Health's Miami Cardiac and Vascular Institute, where I am also Chief of Cardiology at Baptist Hospital and the Chief Population Health Officer at Baptist Health. Over recent decades, new ways of providing cardiovascular care have saved countless lives. And I'm proud to say that at Baptist Health's Miami Cardiac and Vascular Institute, that spirit of innovation is stronger than ever. There's a lot of incredibly innovative stuff happening here. And today I'm happy to welcome Dr. Ramon Quesada to bring us up to date with the latest exciting developments. Dr. Quesada is Medical Director of Interventional Cardiology and the Cardiac Research and Structural Heart Program at the Institute. He's also Clinical Associate Professor of Medicine at the Herbert Wertheim School of Medicine at Florida National University. Dr. Quesada is a friend and colleague for over 30 years, and I'm honored to have him as a guest on the podcast today. Welcome, Ramon.
Thank you, John. It's a pleasure to be here.
So, Ramon, there's just great stuff that you and the team have been doing. I mean, much of it's nationally and internationally recognized. And sometimes in our local catchment area, we don't know as much of what we're doing as others around the country. So this is a great opportunity for us to explore and educate regarding structural heart disease, the incredible accomplishments that you and others have achieved in cardiology, and then maybe a little bit about where we're going as in the future. So let's start with some basic concepts. We use the term structural heart disease. What is that, and how is that a relatively new concept compared to previous forms of heart disease assessments?
So it's fascinating because really our field is a young field. It started in 1979 when Andrea Grunzig did the first balloon angioplasty in Zurich, and then it evolved to what is today a field of interventional cardiology that involves what is called a structural. The structure means that the heart itself. So if the valves are broken, we try to fix it. And if you have congenital defects in the heart, all this was done only with surgical procedures in the past. And now we can take and do that with minimal invasive. The patients are awake, sedated only, and we can intervene with minimal trauma to the body and using catheter techniques. That's basically what a structural means.
So I think that's really a great perspective, because I think it's not that we couldn't help people with these cardiac conditions before, but it generally required a surgical procedure, which certainly had a higher complication concern and a higher recuperation rate. So part of the innovation, Ramon, is really not just to be able to do it, but the patient experience, the patient recuperation, the patient getting back to the quality of life is quicker and enhanced. Would that be the case?
That is the case, exactly that, because and now we can treat patients who are very, very frail, and they were very elderly, that before they were not candidates for surgery. Now with all these transcatheter techniques, we can help them to have better quality of life and better outcomes.
Let's talk about a couple of the main structural procedures, and I know this world is expanding rapidly as we mentioned. So first, TAVR. Lots of reported data in the press, lots of studies going on regularly regarding TAVR. But go back a little bit about the TAVR history, what it is, who's qualifies for it, and your personal experiences. So you were in the leading edge of developing TAVR going back years ago.
So it's fascinating. This starts back in the concept of opening the aortic valve, that is with all the blood when it comes out of the heart, it goes to the brain, to the rest of the body. If you have an obstruction in the orifice, it becomes like a pinhole. The heart has to be fighting, and it becomes very difficult. So the only way to fix that in the past was replacing the valve surgically. It's a very traumatic operation, but it was very successful, and that's the only way to do it in the past. Today, we can replace the valve without opening the chest, and that's what TAVR is all about.
So aortic stenosis, we'll talk a little bit about aortic stenosis, because that's obviously what TAVR is for. So just to speak to that quickly.
Yes, aortic stenosis is obstruction of the aortic valve, and that's really a disease that takes time and to build up. Is a disease that you see in the elderly population, but can happen in the young people who have anomalous or congenital deformation of the aortic valve. We call it bicuspid valve. Younger patient in the 50s, 60s. That for those group of patients, still surgical is an alternative, and a very good alternative to percutaneous approach. But for the elderly patient, for the patient with high risk for surgery, even the low risk for surgery, today we can do it without surgery.
Right.
We can do it without general anesthesia.
People think a TAVR is a disease. I think people think aortic stenosis, I apologize, is a disease of the elderly. And it is more common as one gets older, but we do have younger people who otherwise have these abnormal valves that require replacement. And as you're saying, the evolution is this is done without general anesthesia. People go home within a few days. People don't have that incision in their chest. It's just remarkable. And the other thing you just mentioned, speak to this a little bit. When it first came out, it was really for those high-risk people, the people who had, they would die in surgery. They had no other options. So it was kind of like a salvage procedure. But now, even lower surgical risk people, you're doing TAVRs on. Is that right?
That is totally correct. This is one of the most incredible fields in medicine, I would say, because we prove with scientific data, randomized clinical trials, that number one, replacing the valve percutaneously was better than doing only observational medicine. Because the patient who did observational medicine, they die. They have a lower survival rate than the patient we change the valve. This is a high-risk patient, right. Super high-risk patient. Then
let me stop you there for a second. So basically, people with this condition, when we try to follow them medically and you don't look so bad, don't worry about it, they don't do as well than if we intervene to fix the valve earlier in that disease state. That's what you're saying, right?
That is correct.
Right.
There's no medical therapy for this condition.
Right.
Medical therapy for this condition is we proved that it's not a good thing. The best option is replace the valve.
Right. As
long as you're a candidate, because if you're in the extreme, then there's no benefit of doing this. And I'm probably not going to get into that because it's complicated, but that's a decision that we make in a multidisciplinary approach. So it's not one mind deciding, it's a multiple minds deciding. And that is very interesting. I'm going to take a pause here.
Yeah, please.
Because in 1987, when the institute was founded, it was founded in the concept of multidisciplinary approach to cardiovascular disease, and that was a very innovative concept. Nobody was doing that. Everybody was practicing medicine in silos. The surgeons here, the cardiologists here, the vascular surgeons. Everybody was in their own little world. But we brought a different approach. Let's have all these minds work together for the best solution, which is the patient's well-being. And that's the multidisciplinary approach to cardiovascular disease. That was the institute actually was a pioneer in the country doing this. Today, it's mandate. Once TAVR was approved, it's mandated that the decision to put a patient through these procedures has to be decided in a multidisciplinary consensus form, which is great, which is the best thing that happens. But at the institute, we started with this 20 years before.
Yeah, no, it was very innovative, and now it's the others are caught up, and we're further innovating, and they'll catch up for the newer things we're doing down the road.
That's right.
But I do think for the listeners, it's important if you have aortic stenosis and you may be a candidate for this TAVR, this percutaneous rather than open surgical replacement of the valve. It's a multidisciplinary. It's not one person saying you need a TAVR, I'm going to do it tomorrow. There's a lot of assessments of the person between surgeons and the cardiologist, interventional cardiologist, anesthesiology. We have imagers. Maybe you want to talk for a second before we talk about other procedures, the importance of having high-level cardiac imagers. How does that help you and differentiate the Miami Cardiac and Vascular Institute's TAVR program that you lead from others? Talk about that a little bit.
So this one thing is like everything in life. One thing's take you to the other things, and then when you put it together, it's a beautiful combination. It's like an orchestra. In medicine, is the same thing. When we start the field of structural interventions, we were like the Lone Rangers. The individual, the operator was doing the whole procedure, doing the images, everything. But you cannot do everything. You need to have expertise in different fields. And the new specialty in our field is structural imagers. These are cardiologists who are dedicated 100% of their time to do imaging. I always say it, if you can see it, you can do it. So they bring out to us the expertise to showing us the imaging quality So we can do these complex procedures, and it will work as a team, and also with the cardiac surgeons and the interventional cardiologists who are dedicated into this field, and that brings the results and it reflects in the outcome of these patients and better results.
Patients will do better. They'll feel better. The results will last longer. They'll have less complications when you're able to actually see, using ultrasound technology and various other technologies at the time of the procedure, what actually is going on. And that is a high level of performance that not a lot of centers have, these high level cardiologists dedicated to imaging. It's interesting to me sometimes when patients will, they'll search around, how many hips have you done? If I'm going to take my hip surgery, how many open hearts have you done? But certain things, even like echocardiography, there's really a differentiation between the people who really dedicate their careers towards performing interpretations of these cardiac echoes, at a very high level versus, you go to some diagnostic center down the block and there's some tech who, does part-time echoes. So I think that's a higher level of understanding as we move forward towards that subspecialization expertise. But again, that we bring together in the team. So TAVR was kind of the first of the structural procedures to really take off, and it's still growing and developing. And we have, again, that team-based approach with great outcomes. Let's talk about MitraClip, because to me, again, that's almost more exciting because we can offer people, again, a non-surgical approach to a very serious concern. So can you talk a little bit about mitral regurgitation and then what you're able to do with the MitraClip?
Listen, this is totally fascinating. Let me say, the aortic valve, if you compare the complexity of the valves, the aortic valve is like an odometer of a car. It's broken, you take it out and you put a new one. Simple. The mitral valve is more complex. It's like a cockpit of a 747, very complicated. Multiple pieces, you have to look at them and you have to put them all together and think about it. How are you going to repair when it's broken? Okay, so we repair the valve, meaning that you don't put a new valve, you're repairing the valve. You're repairing something that is wrong with the valve. And then you replace the valve. You have to decide when you repair and when you replace. And I'm going to just mention that the tricuspid valve was a forgotten valve, but now we're also involved in the tricuspid valve. So it's an evolution of all the structural part of the heart that we can repair if necessary. So the mitral valve, it was very complex. This happened almost simultaneously. So the surgeons use a technique that they put stitches in the mitral valve, making like a bow tie. And for that, you reduce the regurgitation or the insufficiency of the valve. So there's two types of insufficiencies. One is a disease of the valve itself, meaning that we call it primary, because the valve is defective or is degenerative, and the valve leaks. It's like it doesn't close when it's supposed to be closed, and it stays open, so you have leaking blood. And the other one is secondary, which the valve is normal, but then it's the muscle of the heart which is abnormal, and that dilates the islets of the valve, and the valve stays open. So it's primary and secondary. So
and the secondary is more seen in patients who also would have heart failure, which is also very common. Right.
The heart is dilated.
And the dilating heart makes the valve leak, and the leaky valve makes the heart worse. So this is the situation.
So back in 2000, because I'm going to, if you allow me, I'm going to go back to the beginning. Because we were
go ahead and say it, and we'll decide if we edit you out afterwards.
So, we started at the very, very beginning. With our interest was in how can we reproduce things done in the operating room, done in the cath lab, without cutting the chest open, and we can do the same things that the surgeon do. So this is this operation that the surgeon did, that they put a ring and then they put stitches in the leaflets. So it's called the Alfieri technique, because Alfieri was an Italian surgeon who described this. So the biomedical engineers they developed this concept with interventional cardiologists that how can we get to the heart and do the same thing, but without cutting the chest? So the idea came and put a clip. The clip does the work of the ring, because it's more than a stitch. So bring the valve together and also reduce the amount of leaking on the valve. So that's the way it started. And then in 2005, around 2005, we were involved in a study called Everest trial, and we used all comers. Good, patients, low-risk patient, high-risk patient, everybody. And we learned several things. Number one, that the surgeon do a beautiful operation. So surgical mitral valve repair is the ideal way of repairing the mitral valve. But in the high-risk patients, those patients who are very high risk of surgery, who have higher mortality, this procedure was superior if you have primary mitral insufficiency. And also in the patient who have secondary MR, which surgery is not a good alternative, is not the best alternative, we proved that it was in patients who failed medical therapy, this was the best way to improve these patients' quality of life and survival. And that's why it got approved. And now we're in the fourth generation of clips. We have small clips, big clips, and whatever. So the combination, we can achieve incredible results and very, very, very complex anatomies and very high-risk patients. But this is only the first phase.
I think that's an important evolution. So TAVR started when we did this, again, this percutaneous, non-surgical approach to replacing the mitral valve. Only, like I said, in people who had no other choice. They were going to die. They couldn't get surgery because they were so frail and sick. Let's just salvage them. Then we started doing it to patients who had a higher surgical risk, but not that sick, and we found it was just as good as surgery. And then we lowered it, that now anyone who needs an aortic valve, TAVR is a particularly viable opportunity, even if you're relatively healthy. We're kind of going through the same thing with MitraClip. When you say where it starts out with just the only high-risk people, they can't get surgery because they're so frail, because they won't survive surgery. But we're finding that there might be benefits going forward in people less of a surgical risk with certain mitral valve conditions. And again, the benefit would be you're avoiding an open heart or a surgical procedure. I shouldn't say open heart, a surgical procedure otherwise. Is that where you see the MitraClip going?
The guidelines just change. So the guidelines change for secondary MR, for secondary mitral insufficiency, transcatheter mitral valve repair with MitraClip we have a classification of the indication. One is the best indication and with the best evidence. 2A is really you have evidence. So we are a 2A indication with MitraClip. Surgery is a 2B. So we were above surgery. So if you have functional MR, which medical therapy is still the gold, but medical therapy is not doing the job, then you should move into mitral valve repair with MitraClip.
So again, take-home point is if you have mitral regurgitation with a normal heart, if you have heart failure with a lot of mitral regurgitation, determine if you're a candidate for this less invasive procedure, which has indications now. This is not an experimental procedure, but certainly you were involved in those early stages. Last one I want to talk to just briefly is the Watchman procedure. Again, we're talking about percutaneous, non-surgical procedures that can affect the structure of the heart. So I'll let the listeners know atrial fibrillation, which is an arrhythmia. We've had previous discussions about this in podcasts and elsewhere. Very common as we get older, leads to a fast heart rate and leads to an increased stroke risk. There's a little pocket off the upper part of the heart where blood clots can form in atrial fibrillation. It's called left atrial appendage. And previously, all we could offer people were very intense anticoagulations, which still work. And the majority of people still benefit from that. But there are people that can bleed. There are people that can have contraindications, can't handle the anticoagulation. So rather than just say, good luck, hope you don't have a stroke, talk about the Watchman and where that's coming into play.
This is another field that really we were lucky enough that we were really at the very beginning. We have participated at the Institute in all the trials, from the first trial that is called Protect AFib. So we have this structure that John is talking about. It's called left atrial appendage. 90% of the strokes induced by clot formation and atrial fibrillation come from this structure. And the reason to anticoagulate patients is to prevent the formation of clots in this left atrial appendage. But what happens if we just close it, isolate it? You can do it two ways. You can open the chest and cut it, or you can isolate it, putting a device that will seal the appendage. And we did 4 randomized trials trying to prove that this little basket called Watchman has, number one, has prevent the complications of atrial fibrillation, which is a stroke, or is equal to anticoagulation or superior. And this is the story that is that we prove that closing the left atrial appendage with a Watchman device, which is a totally percutaneous approach. When we started, we didn't know what the appendage was, to be honest with you. We thought it was a little bad. And we learned that through imaging that each appendage is different for every patient. And we know that depending on the morphology of the appendage, you might have a higher risk of having strokes than with other morphology of appendage. We learned all the stuff through the years of studying this. But this is the thing that we do know. Number one, if you close the appendage, you reduce the chances of having complications of oral anticoagulation by 98%. What is the worst complication? Bleeding into the brain. That's number one. Number two, you reduce the chances of having a stroke compared to oral anticoagulation by thrombus by 30%. The most important problem is that patients who are in oral anticoagulations, they do not tolerate it for a long time. The older the patients, the less they can have oral anticoagulation for long periods of time. And when they become more susceptible to have strokes from clots is when they stop taking the oral anticoagulation. And the fourth is the complications of anticoagulation is bleeding. So the drawback of using a device to prevent this is because it's a procedure. You have to go through the heart, you have to put a device in the heart, and that by itself carries a risk of complications, which today is very, very low. The complication risk of heart perforation is less than 1%. Embolization is almost 0%.
It is, but I do want to emphasize, Sergeant, it is a procedure. I mean, that's like, well, why does everyone get this? And down the road,
yes.
But it's a procedure versus taking a medication. But again, as you said, it's superior to the medication in a lot of ways. But it's early in its development. So down the road, we may find with either improved techniques, it might be a lower threshold to do. But my point is, you're talking about TAVR, which is an aortic valve replacement through a catheter procedure. MitraClip, these clips on the valve that pull them together to decrease the leak for people who have various medical conditions related to that. And the ability to close off this appendage, to seal it off so blood clots don't cause stroke. These are your bread and butter stuff. And quite frankly, you do this routinely. This is not, no one's writing up these cases in the newspapers because this is what you do. This is what we do at the Miami Cardiac and Vascular Institute. So certainly, if people have any of the medical conditions which might be candidates for it, certainly whether they call through their primary care doctor or through a cardiologist, or they can call through a Miami Cardiac and Vascular Institute structural program or atrial fibrillation, we're bringing these people these technologies. And again, it's a credit to you and the leadership team. Final point, Q. I'm sorry, that's my our common call Dr. Quesada, Q. Final point. So we know you've been involved in research, and we've led a lot of research initiatives. We have innovation, as you talked about, doing new techniques and learning from that and bringing it to the broader community. You did mention the unique aspect of Miami Cardiac and Vascular Institute is this multidisciplinary approach. Can you just what differentiates in your mind the Miami Cardiac and Vascular Institute from other cardiac programs in the South Florida?
I think that the concept, and I'm going to give the credit to the founder, because really that was Barry Katzen who believed when he founded the institute that the dialogue among colleagues is the most important thing. Is one mind, multiple minds think better than one mind. And that was the multidisciplinary approach. And if you look even at the design of the cath labs of the institute, they are open. Not because they look nice. They open for the only reason that means that our philosophy. We don't hide anything. We are open. Everybody can come and look at it. And the most important thing, you can ask for help at any moment. And that is, I think, the most important aspect of the multidisciplinary approach. You don't have to be afraid of asking. As a matter of fact,
and again, that's a brilliant point, and that's the doctor we're talking about. I mean,
right.
To me, it's okay for a doctor to say, "I don't really know," or "Let me find out," or "Let me ask someone." When the doctor treats the patient with that ego-driven, "I have all the answers," again, that's where sometimes people get into trouble. So I do think that's worth emphasizing.
And I think that's a change, and I think that's the philosophy even in our own group.
Yeah, I agree.
We have multiple specialties or subspecialties within cardiology in our own group. So you mentioned yourself, you're a lipidologist. If I have a question with a complex patient, I will ask you immediately, what do you think about it? How do we manage this? And we have that that opportunity. That's the philosophy of us at Miami, at MCVI, at Miami Cardiac and Vascular Institute, and I think that brings a difference in everything that we do as a multidisciplinary approach for the best of the patient care.
Well said, Ramon. And again, I just personally, I take such pride and honor, working with you and the team and being able to see and participate and support the incredible innovative work being done. And I think your passion and knowledge has come through, and hopefully the listeners can take that away, which is seek options out there for any cardiac conditions. And we want to provide the best outcome with the least invasive approach when eligible. Before we sign off, listeners, we can really use your help and feedback. Please take a moment to give this podcast a 5-star review on whichever platform you listen to us. Listen to some of our older podcasts as well. Email us with comments or suggestions for future topics at baptisthealthtalk@baptisthealth.net. That's baptisthealthtalk@baptisthealth.net. We'd love to hear from you, and thanks for listening. And until next time, stay safe and mask up.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. This podcast is brought to you by Baptist Health South Florida, healthcare that cares.